Hello, everyone. My name is Shannon Vandenberg. I'm the Assistant Dean of Nursing at the University of Lethbridge, which is located in Alberta, Canada. And I've been invited to share a little bit of the work that I've been doing on climate-driven vector-borne diseases and what this means for us as registered nurses. So this was what I'll be sharing today is some of the results of the work that I did for my PhD dissertation. And I'm happy to share a little bit about what I found. So I'll be talking about registered nurses' knowledge, attitudes, and practices toward planetary health challenges and what I found in this research. So before I begin, I just want to provide a land acknowledgement. The University of Lethbridge is situated on traditional Blackfoot territory. Our university's Blackfoot name is Aniskum, meaning sacred buffalo stone. And as an individual living and benefiting from Blackfoot Confederacy traditional territory, I honor the traditions of people who have cared for this land since time immemorial. So on the photo here, you can see this is our university. We are situated in Lethbridge, which is a city in what we call our coulee. So you can see, we've sort of built the university into the coulees, and then in the bottom, there's a river valley flowing through. So this is what our city is uh, built around these coulees with the river valley. And anyway, it's a beautiful place to live. So I want to honor the land that I live on. I just want to identify a few learning objectives for today. So I'm going to go through the interconnections between climate change, vector-borne diseases, and planetary health, and their relevance to nursing practice. I will highlight the Canadian context. That's where my research took place. I'll talk a little bit about the findings from the National Study on Nurses' Knowledge, Attitudes, and Practices, and then I'll identify some strategies for strengthening nursing education, leadership, and advocacy to ensure nurses are prepared and ready to respond to planetary health challenges. So a little bit of background to the research. Planetary health disruptions, such as climate change, highlight social and structural inequities within populations. When we look at planetary health, Indigenous peoples have long recognized the importance of their knowledge systems and strong connections to the land, responding to and managing environmental change. First Nations, Inuit, and Métis communities in Canada are closely connected to natural ecosystems, where the geographical location of their communities causes them to experience the effects of rapid climate change and planetary decline to a greater extent than other Canadians. And in Canada, we know from the research that Indigenous peoples and those particularly in the northern communities in Canada are impacted by climate injustice. The rising temperatures in Canada's northern regions are threatening food safety and water security, affecting Indigenous peoples' livelihoods, relationship with the land, and overall well-being. So while planetary health has become a term that is more often used, especially in nursing literature in recent years, it is definitely not a new term and one that is rooted in Indigenous culture. And so I want to recognize the importance there that while this is something that nurses are starting to recognize as important within our profession, that we are thinking not only about individual health and public health, global health, but that we're also thinking about the health of our planet and that interconnection between human health and the health of the planet that we live on, but that this is really rooted in Indigenous culture. So we need to recognize and appreciate that. Indigenous knowledge has often been overlooked in favor of Western perspectives in planetary health. And we've seen this in the literature in recent research. To address this imbalance, a group of Indigenous scholars, elders, knowledge holders and practitioners conceptualize the determinants of planetary health from an Indigenous perspective. And so this is what is demonstrated on this slide here, that they've created this image, which includes 10 primary determinants in 3 interconnected levels. So we have the Mother Earth level, the interconnecting determinants, and then the Indigenous peoples level determinants. And these determinants of planetary health offer a holistic compass to assist the global community in moving forward in integrating planetary health in positive ways to ensure sustainable health for both humans and our planet. And as nurses, we can help restore relationships with Indigenous communities, advocating towards self-determination, privileging Indigenous knowledge in planetary health efforts. And according to Redvers and colleagues, who were the creators of these determinants, a formal recognition of Indigenous knowledge as the critical foundation of planetary health is needed. In terms of background, so we know that climate is a very important factor when we're looking at overall planetary health. There's evidence to show that the world's climate is changing, and climate change trends are expected to continue affecting the health of Canadians and the global population. Climatic factors, including heat and increasing temperatures, have contributed to an increasing or expanding geographical distribution of vector-borne diseases. And vector-borne diseases, we're really looking at diseases that are passed through vectors, such as mosquitoes or ticks, and that these diseases are becoming a significant health threat for Canadians. West Nile virus and Lyme disease are believed to be the most common endemic vector-borne diseases in Canada currently, and the current surveillance demonstrates that the incidence of these diseases is increasing annually. I also want to note, though, that while these might be the most common, other vector-borne diseases are expanding into Canada from the United States and other areas and are becoming significant threats, such as the Powassan virus, anaplasmosis, and babesiosis. So we need to be mindful of some of these emerging diseases as well. Reported Lyme disease rates in Canada have increased from 144 cases in 2009 to over 5,000 cases in 2024. And we are expecting that the range expansion of the black-legged tick, which is the tick that carries Lyme disease, is expected to escalate because of climate change, further increasing the risk for humans, particularly in Eastern Canada. West Nile virus fluctuates from year to year. We really see a bit of a boom and a bust cycle here, where we can have years with many cases and then years with very few cases. And it really depends on the weather variations, which affect the reproduction of mosquitoes. But overall, we are expecting a northward range expansion of West Nile virus in Canada. As nurses, we have a significant role to play in mitigating and addressing climate change and vector-borne diseases in practice, given our substantial presence within the healthcare settings. We have a strong commitment to social justice, which provides an opportunity to provide global leadership in addressing health implications related to climate change. And as nurses, we should be prepared to address climate change and health implications, including vector-borne diseases, in our practice. We also have a role in addressing socioeconomic inequities, the shifting unequal power distribution that can create vulnerabilities for some communities, in particular in Canada, our Indigenous communities. And research shows that despite the role nurses can perform in planetary health, that they lack awareness, knowledge, and the resources to adequately address these issues, in these health threats and issues in practice. I conducted a scoping review at the start of this work, at the start of my dissertation work, really to look at nurses' knowledge, perceptions, and attitudes toward climate-sensitive vector-borne diseases, with a specific focus on West Nile virus and Lyme disease. And the results of the scoping review revealed that nurses lack knowledge and confidence regarding climate change, which may affect, and vector-borne diseases, which may affect patient outcomes. And there were no studies examining nurses' knowledge, attitudes, and practices toward climate-sensitive vector-borne diseases, which really prompted then their research to be conducted. And if you are interested in reading more about this scoping review, it has been published in the Public Health Nursing Journal. So to better understand the current context among practicing nurses in Canada, the objective of the research was to explore the knowledge, attitudes, and practices of registered nurses in Canada related to climate-sensitive vector-borne diseases. And this research really emerged from the current planetary health challenges we're experiencing in Canada, as well as the lack of research on the topic. I obtained ethical approval for the research through the Research Ethics Office at the University of Alberta, who manages all the research projects at the University of Lethbridge as well. So there were three primary research questions. The first one was the overall knowledge of vector-borne diseases of nurses in Canada. The second question looked at their attitudes. And the third question was really around practices and experiences of registered nurses in the practice setting. And then I had some comparative questions because I wanted to look at some, if there were any differences among different groups. And so the three secondary or comparative questions were around the knowledge, attitudes, and practices, and whether this varied by position, by education, by practice area, by age, by years of practice, by province or territory, by urban versus rural setting, and by indigeneity. As I already mentioned, planetary health has been more apparent in nursing literature in recent years, but also in mainstream health that we've really moved to this shift toward planetary health. And so I thought that planetary health was a pragmatic theoretical framework, which is useful or appropriate to guide the research in this study. And so positioning the knowledge, attitudes, and practices of RNs toward climate-driven vector-borne diseases offered an assessment of the extent to which nurses are practicing using a planetary health mindset. And I used the planetary health framework by Myers that he introduced in 2017. And the research aligned with components of Myers' illustration, as you can see here on the slide, where we're really looking at anthropogenic changes on human health, climate change as the ecological driver, which causes exposure to infectious diseases as the proximate cause, and then the subsequent health effects, which involve infectious vector-borne diseases. I used a quantitative cross-sectional survey research design. It was informed by the research questions, and this type of research is suitable when we are conducting exploratory research. Knowledge, attitude, and practices surveys are effective in establishing baseline data on a particular topic, particularly when research is lacking, and because there had been no research conducted on this previously, this was an appropriate survey to use. Because this hasn't been researched before, there were obviously no established surveys in the literature, and so we couldn't use an established survey. But the created survey instrument for this research was adapted from Kircher et al., who conducted a qualitative research of the knowledge, attitudes, and practices of healthcare professionals toward climate change and health in Minnesota. And the questions were modified to meet the study objectives to focus specifically on vector-borne diseases, and permission was granted to do this. So the survey tool for this research included 50 items. They were divided into 4 sections: a section on demographics, a section on knowledge, a section on attitudes, and then the final section on practices, experiences, and resources. In the demographics section, we really looked at some of the comparative data that we wanted to obtain. So we looked at things like their primary position, their highest level of education, years of practice, age, province or territory of registration, location of residence, and whether the participant wished to declare indigeneity. The knowledge section comprised 17 questions. 12 of these were Likert scale on knowledge of climate change, Lyme disease, and West Nile virus. The attitude section included 12 items, 10 of which were Likert skill questions focusing on perceptions of climate change and vector-borne diseases in Canada, participants' degree of confidence and preparedness in addressing vector-borne diseases in practice, and nurses' role in social justice and equity-denied populations related to vector-borne diseases. And then the final section contained 13 items about experiences with vector-borne diseases in the practice setting, barriers to discussing vector-borne diseases, if they had ever received information in practice, if they were interested in increasing their knowledge, personal experiences with vector-borne diseases. And to ensure validity, the survey was sent out for expert review to 8 nurse educators and researchers across Canada who were involved in a vector-borne disease project through the Canadian Association of Schools of Nursing. In terms of data collection, the cross-sectional web-based survey was distributed to RNs across Canada using Qualtrics with a respondent-driven sampling technique. Invitations to participate were sent to Canadian provincial and territorial nursing associations, national nursing associations, and nursing specialty and interest groups in Canada. So there were approximately 50 associations in total. And then social media such as Facebook and Instagram are utilized where research announcements were posted to 5 networks of registered nurses. There were 382 eligible survey responses, and of those responses, 35 respondents, or 9.2%, self-declared as Indigenous, so either First Nations, Métis, or Inuit. Data was analyzed using the statistical package for social sciences. Missing variables were replaced with the median when appropriate. Descriptive statistics were generated for initial analyses of survey responses, and statistical significance was set at p being less than 0.05. And tests of difference and association were conducted using ANOVA and ANCOVA for all parametric Likert scale data. The Shapiro-Wilk statistic was used to determine normality, and the result was greater than 0.8 for all knowledge Likert scale items. It was slightly less for the attitude Likert scale items. So to ensure validity and accuracy, both non-parametric and parametric tests were utilized and similar results were obtained. And therefore, I proceeded to use parametric tests on all Likert scale items because the sample size was appropriate and they have more statistical power. And then non-parametric Kruskal-Wallis and chi-square tests were used to analyze comparisons when the data was not normally distributed and classified as ordinal or nominal. In terms of reliability and validity, the reliability testing at Cronbach's alpha coefficient tests were conducted, and the results were greater than 0.8 for survey items, which demonstrates an acceptable level of internal reliability. Significant efforts were taken to ensure a sufficient and representative sample. It was pilot tested with 8 content experts. And then in terms of construct validity, discussion of the alignment of the survey questions to the Planetary Health Theoretical Framework was included in the research write-up. And this was also measured using factor analysis. And then there were it did appear that the education level appeared to be a confounder for province or territory of registration when we were looking at the total attitude Likert scale. And so to ensure validity and accuracy of the statistical results, I used a one-way ANCOVA on this item. I apologize, these are a little bit small, but in terms of demographic information, most survey responses indicated that they worked as a frontline healthcare provider, so almost 68%. Almost 67% of respondents held a baccalaureate degree. Ages ranged from 20 to 66 plus years, and the most frequent category was those between age 36 and 45. Years of practice varied. Most participants, so 30%, indicated that they had practiced between 11 and 20 years. Most respondents indicated that they lived in an urban setting, so 70%, and 9.2% of respondents self-declared as Indigenous, Métis, or Inuit. Most nurses who declared indigeneity worked as frontline care providers. A significant portion were also nurse educators. Most had a baccalaureate degree. Several had a master's degree or a PhD. And the greatest number of Indigenous respondents were from Alberta, British Columbia, Ontario, and Quebec. Survey responses were received from all provinces and territories in Canada, except for Prince Edward Island. The highest number of respondents were from Alberta, British Columbia, Nova Scotia, and Saskatchewan. And a wide range of practice areas were listed on the survey tool, with the highest responses including educational institutions, medical, surgical, nursing, and public health. I'll talk a little bit about the results, try and keep it as high level as I can. Just because otherwise there's a lot of data here, so trying to summarize it concisely. So 95% of respondents were aware that vector-borne diseases are caused by viruses, bacteria, or parasites transmitted to humans from animals or insects. And 78% of respondents knew that Lyme disease and West Nile virus are two prevalent vector-borne diseases in Canada. Only approximately half of the respondents felt knowledgeable about climate change and subsequent health implications, and knowledge of epidemiology, prevention, diagnosis, and treatment of both Lyme disease and West Nile virus was lower than the knowledge of transmission for both diseases. And most participants agreed that increasing their knowledge of vector-borne diseases is a priority for them. When we look at the overall attitude or knowledge score, the overall knowledge of RNs who participated in the study was limited, specifically among frontline nurses and those in Western and Northern regions of Canada. Nurses in Quebec and New Brunswick had significantly higher overall knowledge than nurses in other provinces. And nurses working in public health, educational institutions, as well as First Nations, Métis, and Inuit nurses reported significantly higher overall knowledge compared to nurses in other practice areas or those who did not declare indigeneity. When I compared the means for each disease, participants reported higher overall knowledge of Lyme disease compared to West Nile virus, particularly among nurses working in high endemic areas and Indigenous nurses. And these results can be attributed to the fact that Lyme disease is more prevalent in Canada compared to West Nile virus. And nurses who self-declared as Indigenous reported greater knowledge of both diseases, as well as higher overall knowledge of climate change compared to non-Indigenous respondents. They also placed significantly greater priority on increasing their knowledge of vector-borne diseases. And non-parametric tests showed that Indigenous nurses were significantly more likely to have completed formal education and to consider climate change a factor in Lyme disease and West Nile virus care. In terms of attitudes, most respondents agreed that climate change is happening and that the impacts are felt on patients and populations. 82% of respondents were concerned about health impacts of vector-borne diseases on their patients. And these findings indicate that while nurses agree that climate change is an urgent issue in Canada, they might not be more knowledgeable on the issue than other Canadians despite their education. Most participants felt that nurses are positioned to help patients understand the health impacts of vector-borne diseases, and we should play an active role in discussing vector-borne diseases with our patients. Most agreed that Indigenous Canadians are disproportionately affected by climate change, and as nurses, we should advocate for social justice by looking at some of these socioeconomic inequities that exist among populations at greater risk for vector-borne diseases. Personal preparedness on the attitude items were considerably lower, where most participants did not feel prepared to address vector-borne diseases and did not feel confident counseling patients about climate change or vector-borne diseases. When we look at overall or total attitude scores, the overall score was considered average. Feelings of preparedness among nurses in Quebec was statistically higher than for nurses in British Columbia, Alberta, Saskatchewan, and Newfoundland and Labrador. And nurses who declared indigeneity reported statistically greater preparedness than other nurses. Confidence counseling patients and populations yielded similar results, where nurses in educational institutions and public health reported statistically higher confidence levels, which again could relate to their scope of practice. Higher confidence among nurses was reported in Quebec, which significantly differed from other provinces. And given the higher rates of both Lyme disease and West Nile virus in Quebec, this is not unexpected. That nurses in Quebec would feel more prepared and confident because they're living in a higher endemic area. Indigenous nurses reported statistically greater confidence than those who did not declare indigeneity. And again, this can be attributed to the risk of exposure or practice setting. According to Sanderson et al., Indigenous peoples have solutions to climate-related health challenges, and therefore this finding is not surprising that Indigenous nurses felt more prepared to address vector-borne diseases with patients in the practice setting. And Indigenous nurses were also more likely to agree that Indigenous Canadians face disproportionate climate-related health impacts, and their attitude scores were significantly higher than those of non-Indigenous respondents. In terms of practices and experiences, 34% of respondents had personal experience with vector-borne diseases outside their work or clinical setting, and nurses who declared indigeneity reported significantly greater personal experience compared to participants who did not declare indigeneity. Most respondents had rarely or never encountered patients with vector-borne diseases in the clinical setting, but Indigenous nurses encountered patients more often. Most respondents indicated they do not discuss impacts of climate change or vector-borne diseases on health with their patients or clients. This finding is concerning, given that most nurses were indicated that they were frontline care providers and therefore are well positioned to address the impact of climate on health. Greater number of nurses in Quebec discuss climate change and health compared to nurses in British Columbia, Saskatchewan, Alberta, and Newfoundland. And a statistically larger number of Indigenous respondents also indicated that they discussed climate change and health with their patients. 85% of respondents reported that they had never completed any education, which again could correlate with their limited knowledge scores and lack of confidence by these study participants. "74% of respondents had never received information about vector-borne diseases in their practice setting. Statistically greater number of nurses who declared indigeneity and those working in public health had received information. Excuse me. Given that vector-borne diseases are an emerging issue in Canada, it's concerning that most participants had not received information in their practice setting. According to Auden et al., Lyme disease is ranked second on a prioritization tool for endemic diseases in Canada, which does confirm that Lyme disease is a significant risk. However, other researchers have established that vector-borne diseases are not necessarily given priority in Canada's healthcare system, which could confirm the findings in the current study that most nurses had not received education or information about vector-borne diseases in the practice setting. And this can also really contribute to the reasons why nurses why we really aren't seeing that shift from patient care to planetary healthcare, right? That importance there of recognizing planetary health and moving beyond our individual patients when we're considering our role. 71% of nurses were interested in continuing education about vector-borne diseases if this was available. In terms of barriers, the most common barriers preventing discussions with patients about vector-borne diseases, including lack of knowledge, lack of time, and lack of patient interest. And similarly, the greatest barriers to accessing resources included lack of time, lack of knowledge, and lack of motivation. And these findings are certainly not surprising given the current context of nursing in Canada, where nurses are facing greater workloads, higher patient acuity levels, And when we're looking at the limited knowledge, this could also relate to the perceived barriers. In terms of some key messages, Indigenous nurses reported greater knowledge of climate change and vector-borne diseases compared to other study participants. And again, this is not surprising given the expertise of Indigenous peoples on planetary health issues. The enhanced knowledge of Indigenous nurses on vector-borne diseases may be attributed to their increased risk and exposure, as well as the intergenerational knowledge transfer among Indigenous peoples, which has provided them with the knowledge to observe, respond, and adapt to climate change and environmental health concerns. While nurses agree that climate change is an urgent issue in Canada, they are not necessarily more knowledgeable than other Canadians despite advanced education. This finding demonstrates the need for further education for healthcare professionals in Canada to ensure they're prepared for healthcare practice settings. As I just mentioned, it may also be difficult for nurses to transform the current model of moving from illness care to planetary health care, and this may have impeded nurses' knowledge and understanding of their professional roles in mitigating planetary health issues such as climate change. Higher knowledge of vector-borne diseases was reported by nurse managers compared to frontline staff. This finding is concerning because as frontline care providers, nurses are directly responsible for patient care, and a lack of knowledge of vector-borne diseases can hinder positive patient outcomes. Fourth, there may not have been enough of an emphasis on climate change and planetary health by leading national and provincial and territorial nursing organizations and health authorities in Canada until recently. The 2017 position statement on climate change and nurses' roles by the Canadian Nurses Association was recently retired in May 2024 and was replaced with a new position statement on planetary health, which was released on Earth Day, where the CNA offers guidance for nursing practice, education, research, and leadership. And fifthly, little progress may have been made to integrate climate change concepts into nursing practice standards in Canada, which limits nurses' knowledge and attitudes. And these findings align with the results of the scoping review we conducted in 2023, which found that nurses lack the knowledge and confidence regarding climate change and vector-borne diseases, which contributes to a lack of practice preparedness in addressing vector-borne diseases in the practice setting. I'll offer a few recommendations, and I'll start with education. So given the limited knowledge on climate change and vector-borne diseases revealed in the current study, planetary health, climate change, and vector-borne disease content must be better integrated into nursing curriculums, and I say across Canada, but I would argue globally, to better prepare nurses to address these challenges in their practice. It's recommended that the content on planetary health, climate change, and vector-borne diseases be integrated throughout nursing curriculums and throughout a program rather than as a singular course, because this really promotes a holistic understanding of planetary health. Secondly, I believe that nurse educators should attempt to decolonize nursing curricula and situate topics of planetary health, climate change, and vector-borne diseases in Indigenous perspectives. A broader understanding of planetary health is necessary, where Indigenous values and knowledge are acknowledged rather than silenced. Indigenous perspectives and knowledge on climate change and related health impacts provide numerous opportunities for nursing education, including discussions around holism, sustainability, climate justice, stewardship, relationality, and reciprocity. Co-creation of curriculum content, joint teaching initiatives, and interprofessional learning opportunities should be prioritized. Indigenous and non-Indigenous nurses should be supported to work collaboratively in advocating for the health and well-being of Indigenous peoples within our healthcare system. The determinants of planetary health from an Indigenous perspective should take priority in nursing education programs, because these determinants provide a means to practically lead sustainable health for both humans and our planet. Redverse determinants of planetary health from an Indigenous perspective should be integrated within our programs alongside our social determinants of health and ecological determinants of health to really demonstrate that interconnection of human and planetary health. In terms of practice, nursing regulatory bodies should revise entry to practice competencies and nursing standards of practice to include planetary health, climate change, and health implications such as vector-borne diseases to ensure practicing nurses are prepared to effectively care for patients. Greater attention must be placed on vector-borne diseases in geographical regions of Canada that are not currently highly endemic, such as the northern and western regions, to enhance practice preparedness for nurses in these areas. We should also enhance continuing education for healthcare professionals on climate change and vector-borne diseases in the practice setting. And greater effort must be taken to ensure healthcare professionals are given evidence-informed, reliable information that's accessible and relatable. And education on climate-sensitive vector-borne diseases should be prioritized across all areas of nursing practice, with a particular emphasis on integrating Indigenous knowledge systems that reflect holistic understandings of planetary health. Indigenous nurses are uniquely positioned to lead the profession in advancing the decolonization of nursing knowledge. It's recommended that nurses prioritize planetary health issues both within their personal and professional lives, and nurses are encouraged to assume greater leadership by advocating to and engaging with nursing and healthcare organizations, regulatory bodies, legislators, and governments to act on these issues to advance population and planetary health. Nurses can encourage researchers, policy developers, and practitioners to take a multi-sectoral perspective to develop climate-sensitive policies. And the legislated scope of RN should increase to allow for expanded roles in planetary health and climate action policy advocacy and development. In terms of research, the study provides baseline data on knowledge, attitudes, beliefs, and behaviors of RNs toward vector-borne diseases. However, there's a need for further research to evaluate healthcare professionals' workforce and practice readiness in meeting the challenges of planetary health, which will promote improved practice competence. Research on curricular integration of planetary health, climate change, and vector-borne diseases across Canada is warranted, and advocating for planetary health as a theoretical framework to guide nursing research, education, and practice to ensure nurses are prepared for their roles in planetary health. And I have written an article about this, and it was recently published on the use of planetary health as a theoretical framework in nursing. In terms of the limitations, I recognize that the sample size was small, or only a small percentage of eligible RNs in Canada participated in the research study, despite significant efforts to recruit study participants through various methods over a period of time. When we look at survey fatigue, this can be considered when we're looking at nurses in Canada, as well as the current healthcare context. They may not have the time or the motivation to complete additional surveys or research. And again, for a lot of nurses, they may not have an interest in the topic and so therefore chose not to participate. When we're looking at overall goals and objectives of this study, a greater understanding of nurses' knowledge, attitudes, and practices toward vector-borne diseases has been achieved through the meaningful data obtained from study participants. The goal of this research is that nurses are better prepared to address vector-borne diseases in the practice setting and assume a greater role in leading change to advocate for planetary health initiatives to improve overall population health. Thank you for your time. If you do have further questions, please feel free to contact me. My email is my first stop, my last name @uleth.ca. Thank you again.